Welcome back to MLT 120. This lecture will be on anemias. This lecture will be divided up into two parts. We have two main ways that we classify our anemias. We either classify it through morphology, which is referring to the structure or how it's put together, or it's classified based on the cause of the anemia. Okay, let's first define what anemia is. When we first think about anemia, or most often when we think about anemia, we think about a decrease in the red blood cells. But anemia can also refer to a decrease in the hemoglobin or a decrease in the hematocrit. And remember, our acronym for hemoglobin is HGB. And I don't think we've talked about it before, but our acronym for hematocrit is HCT. And we'll be learning how to do a hematocrit lab in our on-campus laboratory session. Our normal range for our red blood cell count, hemoglobin, and hematocrit are all based on a normal population. So a population that's not sick or diseased. So what or how many red blood cells did we say are in the normal range for a normal human? Remember, we said they have about 4 to 6 million red blood cells per microliter. Also, normal ranges are based on the age of people, their biological sex, and also different environmental conditions. Let's talk about some environmental conditions or factors that can affect your normal red blood cell range. Altitude is the first one. Higher altitudes equal a lower oxygen content in the air. So that means that you're going to have an increase in erythropoietin in the body. Remember, the hormone erythropoietin is produced in the kidneys, and when the kidneys produce erythropoietin, thus it increases your red blood cells. So you'll have an increased red blood cell range at a higher altitude to make up for less O2 being in the environment. That's why, for example, they want the Olympic Training Center in Colorado, because Colorado has a higher altitude, so there's less oxygen in the environment or in the air in Colorado. So when the athletes train in Colorado, they'll actually have more erythropoietin and they'll have more red blood cells, giving them a little bit more advantage versus if they trained here in North Carolina, which is at a lower altitude. And this can kind of lead into us talking about the whole Lance Armstrong blood doping scandal. The whole concept of blood doping is either injecting yourself with the hormone EPO, erythropoietin, to increase your red blood cell range, to give you more O2 in the body and give you an advantage athletically, or also you could just have blood transfusions to give you more red blood cells, to give you more oxygen, that would also give you an advantage as an athlete. So that's kind of what Lance Armstrong got in trouble for, which is not an environmental thing, but that kind of goes hand in hand into talking about Olympics and erythropoietin, the hormone. The next environmental factor is smoking or lung conditions can affect your normal red blood cell normal ranges. And this is because conditions that affect the lungs cause lower oxygenation, and this causes a release of erythropoietin to help compensate, and thus there's an increase in red blood cell production. Okay, we said that anemias are classified either based on morphology or cause. So let's talk about morphology. Remember, morphology is referring to structure. So we're talking about red blood cell size and also the red blood cells hemoglobin content. But before we get into some different categories under morphology, let's talk about some key terms that we need to know and understand. So let's look at the key over here on the far right hand side. So anything that you see with cytic on it is referring to the cell itself. Anything you see with chromic is referring to color. Macro is referring to larger. Normo is something referring to something that is normal. Micro is referring to something that is smaller. Hypo is referring to something less or lower. And then hyper is something that's referring to something that is increased. So let's look at the different categories that's under morphology. We can have a red blood cell that's referred to as macrocytic normochromic. So if we break that down, macro is referring to larger, cytic is referring to the cell. So a larger cell is the first part. Normochromic. Norma's normal. Chromic is referring to color. So a larger cell that is normal colored. If you're putting all of your parts of your words together. So this is a larger than normal size red blood cell with a normal amount of hemoglobin, because our hemoglobin is inside of our red blood cells. That's what's going to constitute what color our cell is. Okay, so if it has a normal amount of hemoglobin, it's going to be a normal colored red blood cell. And some examples of red blood cells or anemias that would fall into this macrocytic normochromic category would be our pernicious anemia, which is an anemia where you can't absorb enough B12. Our B12 deficiency, which may lead to a decrease in red blood cells. And then our folic acid deficiency, and that can cause fatigue and even mouth sores. And folic acid is a type of vitamin B. Next up, we have our normocytic normochromic. So if you break those words down into parts, our normocytic, that would be a normal cell of normal color. So our normal size red blood cell with normal amounts of hemoglobin. Because remember, the amount of hemoglobin in the red blood cells constitutes the color of the red blood cell. So some examples of this type of red blood cells as far as anemia is aplastic anemia, and this is anemia where there's a bone marrow failure. Also, you could have normocytic normochromic red blood cells in just acute blood loss. Also in PCH anemia, which is caused by a presence of cold reacting autoantibodies in the blood. And PCH stands for paroxysmal cold hemoglobinuria. It's also sometimes referred to as Doneth-Landsteiner hemolytic anemia syndrome. The last example under this category is PNC, which is proximal nocturnal hemoglobinuria, which leads to premature cell death and impaired production of cells. The last category on this slide for morphology is microcytic hypochromic. Micro referring to less cytic cells, so less than normal size cells, red blood cells, and then hypochromic, so less color. So smaller than normal red blood cells and lower than normal hemoglobin. So they're going to be lighter in color. And some examples of this type of anemia that fall in this category are our iron deficient anemia and our thalassemias. And our thalassemias, we're probably not going to talk about part 2 of the lecture on anemias, but they are inherited blood disorders that cause the body to have less hemoglobin than normal. In the second category of anemias would, of course, be our causes, and our causes can be because of decreased production of red blood cells and hemoglobin, or an increase in destruction of or loss of our red blood cells. Now we're going to get into some of the specific anemias. We talked about a few on the previous slides, and we briefly did kind of an overview, but we're going to get into some of the nuts and bolts of each of these anemias. So for each anemia, specific anemia, make sure that you know the cause, whether it's a decreased production or increase, and also know the morphology, the red blood cell morphology associated with that anemia. The first type of anemia that we're going to get into is aplastic anemia, and we've already mentioned this is a complete bone marrow failure, and this is where we have something called pancytopenia happen, and this is meaning that there's a decrease in all cell lines. The bone marrow is also suffering from hypocellularity, meaning that there's a reduced number of hemopoietic cells present in the bone marrow. Remember, the hemopoietic stem cells is where all of our blood cells come from. That's how they start out. And the most noticeable effect is anemia. So let's look real quick at our little image over here on the right hand side of the slide. Our bone marrow gives rise to all of our blood cells, whether it's our red blood cells, our white blood cells, or our platelets. So in this anemia, there's a complete failure of our bone marrow. So we're going to have a complete failure of producing any of our cells, whether it's our white blood cells, red blood cells, or our platelets, and that's going to result in anemia. Now, there's some different ways that you can acquire aplastic anemia. It can be idiopathic, meaning the cause is unknown, or it can be secondary to chemicals, drugs, radiation, even chemotherapy, or a virus that you've been exposed to, such as Epstein-Barr. And the Epstein-Barr causes infections like mononucleosis, which is also referred to mono or the kissing disease, and viruses such as hepatitis B and hepatitis C. Another way you can end up with aplastic anemia is through an inherited disorder called Fanconi anemia. This is a chromosomal instability disorder. And if you'll look down at the bottom of the slide, you'll need to make sure that you remember this information in red. Remember, I said you want to make sure and commit to memory the red blood cell morphology and the cause for each anemia. So the red blood cell morphology for aplastic anemia is normocytic, normochromic, and the cause is decreased production. And again, it's decreased production because we have a failure of our bone marrows to produce the blood cells. So let's have a question about the information that we just learned. So think about it. Why would we see a lower number of polychromic erythrocytes, aka reticulocytes, in a blood smear in a patient with aplastic anemia? So think about this and pause the video before you go on to the next slide to get the answer. The answer is we would have a decrease in the number of reticulocytes because the patient with an aplastic anemia has a bone marrow failure, thus not able to make enough red blood cells, thus less reticulocytes. So basically what that's saying is we have a bone marrow failure, so we would never get to this point in the maturation sequence of even having reticulocytes. Next, let's talk about iron deficient anemia, or IDA. This is the most common anemia in the U.S., and you see it more in women than men. Some tests that we use in the lab to test for iron deficient anemia include our CBC count. The retics may be low, or reticulocytes may be low, and the serum iron and the ferritin. Remember, our ferritin is our storage iron that's in the liver, may be low. So the iron balance is influenced by the amount of iron ingested in our diets, the amount of iron absorbed in the intestine. So this is an intestinal problem. Or the red blood cell formation using recycled or new iron, and then iron loss through blood loss, and can be through chronic blood loss. And our red blood cell morphology for this anemia is microcytic hypochromic. And you may also see something called target cells. So let's talk about what a target cell looks like. So this is what you would see under the microscope for a target cell. And it's referred to as target cell because it almost looks like a bullseye. Your red blood cell is going to have this center, what's referred to as the bullseye, and then it's going to have a ring, which would be part of the central pallor, and then it's going to have this outside darker ring. Also, your target cells are referred to as a podocyte. So those two terms are used interchangeably, a target cell and a podocyte. And this is if you're looking straight down on top of the red blood cell. If you happen to see the red blood cell from a side view, it's referred to sometimes as a bell-shaped red blood cell. And this would be if the top of the red blood cell would be, and I'm not the best artist, this would be what your red blood cell roughly looks like. This part here would be the top of your bell, and this outer rim of the bell would be this outer edge, and this would be a bell shaped cell. Supposed to be an E. And the cause of iron deficient anemia would be decreased production. So now we have another think about it question. Why would we see a decreased serum ferritin result in the earlier stages of IDA rather than the actual serum iron? Make sure you pause the video and try to answer it on your own before you go on to the next slide with the answer. The answer is because the ferritin is our stored iron, so that's the key. It's stored in our liver. And in the early stages of iron deficient anemia, the body can still dip into its stored iron supply. Thus we're going to see a low ferritin result before we begin to see it in our serum ferritin result. So during low times of iron need, the body will dip into our stored iron first, which is our ferritin, to compensate first. Let's do another quick think about it question. Why can a condition that causes chronic blood loss eventually result in iron deficient anemia? Again, pause and try to answer this on your own before you move on to the answer. And the answer is, after bleeding over time, patients or chronic patients will eventually dip into stored iron in the liver and then will become iron deficient as the body compensates for the loss of blood by the bone marrow making more red blood cells to help compensate for the low red blood cells and hypoxia. Remember, hypoxia is low oxygen. And then they will finally deplete the iron stores and develop iron deficient anemia. So basically what this is saying is the body will dip into stored iron to help compensate after the blood loss. The next anemia we're going to talk about is microcytic, or also referred to as megablastic anemias. If an anemia is due to vitamin B12 and folate deficiency in the diet, it's known as megaloblastic anemia. Okay, megaloblastic is meaning very large red blood cells. So let's look for a comparison over here on our image. This is our normal size red blood cell. So this would be a megaloblastic, so very large red blood cell. If it's not related to a nutritional deficiency, we usually say it's macrocytic. It's a macrocytic deficiency. Again, it's a large red blood cell. It's usually caused by a different reason. And some examples for reasons why it might be macrocytic might be from chemotherapy treatment, maybe alcoholism, or even chronic liver disease. Some reasons that the body needs vitamin B12 and folate is for DNA synthesis and also for cell division. A lack of B12 and folate will result in asynchronous maturation of cells, meaning the nuclear cytoplasmic age will not correspond, and the result you'll end up with a macrocytic normochromic red blood cell. Also, in our white blood cells, you might see something called hypersegmentation, in particular in our neutrophils. And to know what that looks like, look at our image again. These two images are of neutrophils, which is a type of white blood cell. And this is a normal white blood cell, or a normal neutrophil. You have about 3 to 5 segments normally in a neutrophil. This happens to have 4 segments, 1, 2, 3, 4. But with hypersegmentation, you have more than that standard 3 to 5 segments. Look, this one over here has 1, 2, 3, 4, 5, 6, 7, 8. So this is a hypersegmented neutrophil. Next is pernicious anemia, and it's a subset of the megaloblastic anemias, and we need intrinsic factor to absorb our B12. So what is intrinsic factor? It's a glycoprotein needed for absorption produced in the stomach. So in many cases, patients produce intrinsic factor blocking antibodies. So this is ultimately an autoimmune problem. Let's talk about some different ways to test for pernicious anemia. The old way was called the Schilling's test, but more recently we'd use serum samples to test for intrinsic blocking antibodies. But let's talk about the Schilling's test, because that shows up a lot of times on certification exams, what exactly the Schilling test is and how it works. You use a radioactive tag attached to vitamin B12 that's administered to the patient. And in a pernicious anemia patient, they're not able to absorb B12, and you use what's called a scintillation counter to detect the radioactive labeled vitamin B12 that pass into the urine. So that's basically what this is showing down here. So this test can tell you whether you have a dietary B12 problem or an absorption B12 problem. So let's walk through all the steps of the Schilling's test down here at the bottom. So you have a radioactive B12 oral medication administered to the patient. So that's what this pill is the patient is taking. Also, you have an injection of a non-radioactive vitamin B12 given. So that's this step here. You wait 24 hours. The patient waits 24 hours. And then you measure to see the urine sample. You collect the urine sample. And if there's an increase in the radioactive labeled B12, there's a dietary deficiency. If there's a decrease in the radioactive labeled B12, there's an absorption problem. One last thing on this slide, make sure you know your red blood cell morphology, macrocytic, normochromic, and the cause is decreased production. Okay, we have some anemia trivia time. Which of the following adequately describes the pathophysiology of the macrocytic normoblastic anemias? Is it A, lack of DNA synthesis, B, lack of iron in the diet, C, deficient in globin chain structure, or D, deficient in globin chain synthesis? Pause the video before you go on to the next slide to find the answer. The answer is A, lack of DNA synthesis. Next, we're going to discuss hemoglobinopathies. There are actually many hemoglobinopathies out there, but we're going to focus on 3. We're going to focus on sickle cell. It's also referred to as hemoglobin S, and we're going to talk about hemoglobin C, and we're going to talk about hemoglobin SC. So what is hemoglobinopathy? It is a structural defect in the hemoglobin molecule from a single amino acid substitution in one of the globin chains. Primarily, it usually affects the beta chain, thus it is a qualitative problem, meaning the quality or the structure of the globin chain is inherited. For the red blood cell morphology for these cells, the red blood cells are normocytic, normochromic, but you will see an increase in those target cells we discussed earlier. The cause is an anemia of increased destruction or loss. The first in that hemoglobinopathy category we're going to talk about is sickle cell, or what's also referred to as hemoglobin S. Sickle cell is usually more prevalent in African or the African American population. This is where the amino acid valine is replaced with glutamic acid on the 6th position of the beta chain. So it can cause the formation of hemoglobin S or sickle cell anemia. It polymerizes when the red blood cell passes through an area of low oxygenation. So that means it goes from the normal biconcave disc shape of a red blood cell, and it causes the red blood cell to sickle. And this is the normal red blood cell, and this is the sickle shape. So the cell becomes rigid and it sickles, which can obstruct small blood vessels. So your normal red blood cell is a biconcave disc, but the sickle that forms in hemoglobin S has rigid, rough edges, and it causes your blood vessels to become blocked because they cannot easily pass through those blood vessels. Also, the spleen wants to remove those sickled red blood cells because they're not normal. So a lot of times they're taken out by the spleen. Also, the sickled red blood cells have a decreased lifespan due to their rigid shape. So this type of anemia, sickle cell anemia, is classified as a increased destruction or loss anemia because a lot of times those red blood cells are taken out by the spleen because of their abnormal shape. So let's talk about the inheritance of the sickle cell disease. Okay? In order to have sickle cell disease, you must be homozygous. You have 2 hemoglobin S genes, one you inherited from each of your parents. So one you inherited from your mother, one gene you inherited from your father in order to have the disease. You can carry the sickle cell trait. This is called heterozygous. This is meaning that you inherited one of the hemoglobin S genes from one parent, and then you inherited the hemoglobin A or the normal carrier gene from the other parent. Normal patients have 2 normal hemoglobin A genes, so they wouldn't have the hemoglobin S gene at all. So let's use the Punnett square to determine the chances of inheritance on the next slide. So the question that is posed is, if two sickle cell carriers produce offspring, what percentage of the offspring will be carriers, what percentage will have the disease, and what percentage will be normal? Now let's look up here at the top. A normal person's genes will be AA. A sickle cell carrier's genes will be SA, meaning one gene from one parent was the S gene and one gene from the other parent was the A gene. So that person is just a carrier. They don't have the disease. They're just a carrier. And then the sickle cell person, they inherited two S's from their parent, meaning they inherited the sickle cell gene from their mother, and then they again inherited the sickle cell gene from their father, so they do have the disease. So the question is, we've got two parents that are carriers, and they are producing offspring. So if you draw out your Punnett square, and you put one across the top as one parent as the carrier, as a carrier, having SA for genes, and the other parent being a carrier, having again genes of SA, you're going to end up with 25% chance of one offspring being SS or having sickle cell disease, and another 25% of an offspring having AA or being normal, not having the disease or being a carrier, but you have a 50% chance of a offspring being carriers of the disease. They don't have the disease, but they're carrying the gene for the disease. Here's just a review of the possibilities for our Punnett square. And just a note for the sickle cell carriers, most sickle cell carriers lead normal lives and only have very mild anemia symptoms. They may not even realize that they are a carrier of that sickle cell gene. However, if two carriers produce children, if two carriers of the sickle cell gene produce children, they do have a 25% chance of having a child with the sickle cell disease. One interesting fact about sickle cell is that people with the sickle cell trait usually have resistance against the parasite Plasmodium falciparum. And this is one of the species of microorganisms that cause malaria. And the reason for this resistance is that cell membranes of cells that sickle get stretched and are misshapen, so that cells end up losing their nutrients. And the parasites need the cell's nutrients to survive. So because of this faulty cell, the parasite ends up getting destroyed or eliminated along the way with the cell. Now, under the hemoglobinopathies category, let's talk about hemoglobin C disease. This is when the amino acid lysine replaces glutamic acid on the 6th position of the beta chain. The patient can either have hemoglobin C disease or they can carry the hemoglobin C trait. In hemoglobin C, you will see what's referred to as bars of gold, and these are crystals, or what's referred to as Washington monuments. And again, these are crystals that you will see in your red blood cells, and that's what you're seeing over here in the image on the right hand side. These are what's referred to as your bars of gold or your Washington monuments, and those are crystals. Also, people might refer to the red blood cells as envelope shaped or pocketbook shaped. You may also see your target cells in an example of a blood smear of a person with hemoglobin C. This one right here looks like it's a target cell. You see that kind of bullseye in the center. Inheritance is the same as with hemoglobin S, and you can use a Punnett square again to determine the percentages of outcomes for hemoglobin C disease. The last hemoglobinopathy we're going to focus on is hemoglobin SC. Again, there's many out there, but this is the last one we're going to focus on. This is a combination of hemoglobin S and hemoglobin C. The patient inherits one S gene from one parent and one C gene from the other parent. So in the beta chain, at the position of 6 of one beta chain, the substitution is valine for glutamic acid. And the other beta chain at position 6, it is a substitution of lysine for glutamic acid. So again, it's a combination of hemoglobin S and hemoglobin C. So in an example of a patient with hemoglobin SC, you would see something called intraerythrocytic crystals in your red blood cells. And you could also see target cells. So what would these cells look like? Well, the arrows are pointing to some of these crystals on the right-hand side in the image. So these are crystals within our red blood cell or our erythrocyte. These are usually irregular shaped crystals. Sometimes people say they look like little mittens. This one right here is kind of turned upside down. This would be the thumb and the rest of the fingers. But again, they're usually irregular shaped crystals within the red blood cell. So now we need to talk about hemoglobinopathy testing. So we have a screening test for sickle cell. This is called the tube solubility test or the dithionite test. This is where you have reagents in a tube and it causes the hemoglobin S to precipitate out. So it either causes a result of either the tube to be cloudy or clear. If the tube is cloudy, that indicates a positive screening test for sickle cell. If it's clear, it's a negative test. But there is a problem associated with this test. The hemoglobinopathy, such as hemoglobin C or SC, can cause a positive or cloudy result for this test. So that raises some problems for this test if you're just looking for sickle cell or hemoglobin S. So if your screening test is positive for the tube solubility test, if it's positive, again, that's just a screening test, you need to order a hemoglobin electrophoresis for confirmation. Okay, the tube solubility test is just a screening test. Once you have a positive screening test, you need to confirm it with a electrophoresis test. So that's what this is on the right hand side of your slide, is the electrophoresis test. Again, this is the confirmation test for sickle cell. Let's talk about how the electrophoresis test is set up and how it works. First, you have a cellulose acetate media that is laid in the chamber, and it's usually a pH of about 8.6, and your samples are put into the wells. These would be your patient samples that are put into the wells, and they're going to run along this gel matrix of the cellulose acetate. And they're going to run, and you're going to have a power source that this is hooked up to. You're going to have a positive and negative that this is hooked up to, and those samples are going to run across this gel. And depending on where they stop along the gel, it's going to tell us what type of hemoglobin that person has. And the most common pattern that it runs in is the CSFA. And these are, or an easy way to remember that is our cheat to remember, our little saying to remember it is crawl slow, fast, accelerate. The C is representing crawl, the S is representing slow, F is representing fast, and A is representing accelerate. And again, that's just a way to help us remember. And those are the different types of hemoglobin, how they run across the gel. You can also use another type of gel to perform this test. You can also use citrate agar at a pH of 0.6. So if we come over to our example here, this is our gel, and this happens to be the side where we're going to put our patient samples in, and the negative probe is here, and this is the positive probe. So our hemoglobin A2 samples ran to right here. Our hemoglobin S samples ran to right here. Our hemoglobin F samples run to right here. And then hemoglobin A samples run right here. So hemoglobin A would be a normal adult. That should be the only type of hemoglobin they have. Our normal newborn, remember our newborns can have hemoglobin A and hemoglobin F. Our sickle cell disease patient is only going to have the hemoglobin S. The patient that's carrying the sickle cell trait, they're going to have hemoglobin A for a normal adult, but also you're going to have the sickle cell trait showing up. For the hemoglobin SC disease patient, you're going to have the hemoglobin S showing up, and also the hemoglobin C. That was also one that was in that category. And then this is the control, and it should actually have all four possibilities, because this is just the control that was ran during the test. So this is our crawl, slow, fast, accelerate across the bottom. Our hemoglobin C drops out first, then our hemoglobin S drops out, then our hemoglobin F drops out, and then finally our hemoglobin A travels the farthest across the gel if you're using the cellulose acetate at pH 8.6 for the electrophoresis. Okay, let's do another trivia question. Which of the following laboratory tests is the confirmation or the definitive test for hemoglobin S? Is it the dithiamide tube test, the osmotic fragility test, the Schilling's test, or the hemoglobin electrophoresis? Pause it before you go on and try to answer it on your own. The answer is D, the hemoglobin electrophoresis. Okay, one more trivia question. A patient's blood smear shows normochromic, normocytic red blood cells, target cells, and crystals that can be described as bars of gold. Which abnormality in the hemoglobin structure is most likely? Is it A substitution in valine for glutamic acid at the 6th position of the beta chain? Or B, a substitution for lysine for glutamic acid at the 6th position of the beta chain? Or C, decreased production of the beta chains? Or D, decreased production of the alpha chains? Pause it and try to answer it on your own before you move on. And the correct answer is B, substitution of lysine for glutamic acid at the 6th position of the beta chain. This concludes part 1 of our lecture on anemias. If you need clarity or help on any of the topics that we covered so far, please don't hesitate to reach out, and I will see you over in part 2.